the refreshing tea break. We're going to have a rapid fire session with the CAD RADS 2.0 by Dr. Sandeep and Dr. Vinit. Over to you.
Alright, so we are going to quickly summarize CAD RADS 2.0 because some of you guys are not using it in clinical practice. So we'll do a quick recap of the CAD RADS and then we'll go from there. Yeah, and Borek was also supposed to be doing this with us, so unfortunately couldn't be here. But he contributed cases. So CAD RADS classification, originally 1.0 came, I don't exactly remember, was it 2017? 16, 17, and it's basically classified from 0 to 5, so 6 categories. 0 is no plaque, no stenosis, 1 is minimal, 2 is mild, 3 moderate, 4 severe, A is single vessel, B is multi-vessel or left main, 5 is occlusion. And then we have modifiers. Originally there were 4, N means non-diagnostic, V means vulnerable plaque, G meant graft, bypass graft, and S is stent. And then this is the summary of the changes that happened between 1 and 2. So in new system, grading system is still the same, 0 to 5, and percentage thresholds are the same. Then we have plaque burden grading. In initial version, there was no place for plaque burden grading. Now we do. There is a four categories from P1 to P4. There is no 0 here. And then we now have 2 more modifiers. One is ischemia, so CTFFR and perfusion basically. And there is one more for exceptions. The CAD RADS 1.0 was basically for atherosclerosis only. All the gradings that we used was just for atherosclerosis. Now we can use modifier E, and whatever the cause of narrowing is, we still grade the narrowing and then we put an E after it if it is narrowing other than atherosclerosis. And then V became HRP in the new system, high risk plaque, and N is still the same, S and G are still the same. Alright, so plaque burden, again mild, moderate, severe, extensive. It can be based on calcium score, it can be based on visual, and it can also be based on segment involvement score. So calcium score is 1 to 100 P1 and so on, more than 1000 P4. Segment involvement score is number of vessel segments involved, and visual is just qualitative assessment. And then there is a modifier I, which means ischemia. So if a patient was CAD RADS 3 and now you send for FFR, it came positive, you include I plus. If it was negative, you say I minus. If it was equivocal, you say I plus minus. And then exception can be any other pathology. If you see any other pathology from coronary atherosclerosis, you put an E modifier at the end. And then there are special guidelines for outweight staple, and we don't need that for this talk. Alright, so yeah, first case.
Alright, so let's set the adrenaline a little bit higher mode, and everybody has had their tea and coffee. So let's take the first case, 35-year-old with chest pain, strong family history of young MI in 30s and 40s. We have calcium score of 0. These are curved plenary formatted images of the RCA and the extreme left, LA in the middle, and circ on your right. And you can see that there is no plaque and there is no stenosis. Even though calcium score is 0, you have to pay attention if there is non-calcified plaque to calculate segmental involvement score, which was 0 in this case. So diagnosis here is CAD RADS 0. When there is CAD RADS 0, you don't have to say anything about plaque unless it is present. Over to the next one, 64-year-old female with chest pain, intermediate pretest probability of obstructive CAD. Again, curved planar reformatted images. And on these images, you first of all, you see that these images are a little bit noisy, and that's because this patient is very big, and that's why the images look very grainy to you. But on the zoomed image there, you can see that there is a fleck of calcium in the left main as indicated by the arrow. So there is definitely, this is not a CAD RADS 0, it's CAD RADS 1, I would grade that as. and because there is one segment involved, I would say grade it as CAD RADS 1 P1. Let's continue on here. Next one, 47-year-old male with chest pain, intermediate PTS probability for obstructive CAD. And what do people think? Like, raise your hand if you think this is a CAD RADS 3. Raise your hand if you think this is CAD RADS 1. Raise your hands if you think this is CAD RADS 2. Okay, most people think it is CAD RADS 2. What about calcium score? Calcium score is 34. Segmental score is 3 though. So would that be P1 or P2? P2, excellent. So this is CAD RADS 2 P2.
Yeah, whichever is the larger number.
You have to go with the larger number. Alright, next one. This is history of chest pain, 70-year-old female with hypertension, family history of CAD. You see curved planar MIPT images of the right coronary artery. You see that there is calcified plaque in at least 2 segments. Calcium score is 50. And on that right sided image, you can make out the degree of stenosis a little bit. Raise your hand if you think this is CAD RADS 3 or 4. How many people for 4? How many people for 3? Okay, I read this as CAD RADS 3, and because there is calcium score of 50, I gave a plaque burden of P1. Alright, next one is a case of this. Because this is CAD RADS 3, we send it for CT FFR. We don't send all the cases for heart flow analysis, we only send 3, and if there's going to be a big difference, single vessel versus multiple vessel, then we send occasional 4As and 4Bs, but usually we only send CAD RADS 3. So we send it for CT FFR, and here is a CT FFR picture, and you can see that there is no hemodynamically significant stenosis in that segment. So then modified CAD RADS on the follow-up report was CAD RADS 3 P1 I minus. I minus meaning that there is no stenosis. Next one, 72-year-old with chest pain, CAD is 0, but there is segmental involvement score of 1. Raise your hand if you think this is CAD RADS 4A. Raise your hand if you think this is moderate, CAD RADS 3. Okay, I see people, most people voting for CAD RADS 3, which is exactly right, and because there is segmental involvement score of 1, we have to go with CAD RADS 3 P1 for this case. Alright, next one is a sub-analysis of this case. We send it for CTFFR. CTFFR value is 0.68. So just want to highlight that you are going to get multiple numbers on the CTFFR. The number that matters the most is about 10 to 20 millimeter distal to the location of the lesion. That is the number that is most reliable, and that is being proven by the literature, as Vinit is pointing out. At that site, this number was 0.63. So how do we read this? So we say if it is more than 0.8, it's normal. Right? If it is between 0.8 and 0.75, it's likely hemodynamically significant. If it is less than 0.75, then we say definitely significant. And this was a definitely significant lesion. Here are diagnostic as well as post-intervention invasive coronary angiogram pictures showing that the stenosis was confirmed on CAP and patient underwent revascularization. So CAD RADS 3 P1 I plus was the example here. Next one, please note the age of this patient. So this is a patient who's 10 years old. Finding has already been identified for you that there is a severe-ish looking stenosis of the left main. How many people think this is CAD RADS 4A? Now, how many people think this is CAD RADS 4B? Excellent. So please note that involvement of the left main, which is more than 50% stenosis, right? That threshold is different for left main. For left main it's 50%, for rest of the vessels it's 70%. So if you have a left main stenosis greater than 50%, it is automatically an upgrade to CAD RADS 4B. And because segmental score was 4, we rated it as CAD RADS 4B, P2. But hang on a second, I said please note the age of the patient. So please raise your hand if you think this is secondary to Kawasaki disease. Raise your hand if you think this is multisystem inflammatory disease secondary to COVID. Last option, familial hypercholesterolemia. Excellent. So we are all on the same page here, correct. That was the diagnosis here. These patients get premature atherosclerosis. Screening for these patients need to start very early, particularly as they enter their teens. In the United States, they get regular visits from preventive cardiology, and then the screening starts typically between 8 and 10 years old. I think
All right.
over to Vinny.
Yeah, I'm there. So 76-year-old male with chest pain, and we have a cine playing over here, and then we have shown there is a stent and there is some kind of arrow in the RCA, and we see a lot of plaque. In the RCA there is at least 3 segments involved. Circumflex there is at least, I think, even 3 segments I can see, and left main and LED. So I see 8 segments involved, and this RCA doesn't look good. So how many do you think it's a CAD RADS 4B? How many think it's a 5? Yes, that is the correct answer. And for modifier, how many of you think it's a P3 or P4? How many for P4? Yes, so I counted 8 segments, so 8 becomes a P4. So, and also there is a stent. So S is for stent. So modifier P, let's talk a little bit again, just a quick recap for because that's kind of most tricky and new. So calcium score, I mean, on these images it's hard to quantify. So here S segment involvement score is more relevant. Less than or equal to 2 is P1, 3 and 4 are P2, 5 to 7 are P3, and more than or equal to 8 is P4, as in this case. And also again, important to highlight, you can do calcium score and also do segment involvement, and they might not have to agree every time. Like in this case, segment involvement is 3, which gives you a P2, and a calcium score of 34 is a P1. So whichever of these two gives you a higher P number of P, that is more relevant. So in this case, we'll use P2. All right, next question. A 71-year-old male with chest pain, and we see there is some plaque in this left anterior descending. Is that left anterior descending? Looks like. And then we have this partly calcified plaque. Looks quite bulky, positively remodeled. And we have this ROI here, which gives you a mean attenuation of around 30 ounce per unit. And stenosis kind of, maybe. How many think it's a moderate stenosis? How many think it is severe? Some people are just marking all correct. Yeah, it was called moderate, and because what modifier should we use for mean attenuation of 30 with positive remodeling? 2 features in single plaque, HRP, and because segment involvement here we only see 1 vessel, but it was 4, so it will, and with a calcium score of 10, segment involvement of 4 will supersede it, and so it will be a P2. So it's a CAD RADS 3 P2 HRP. All right. Next question. So in this case, we see something different. We clearly see there is this left main LED. LED has this quite significant looking stenosis. There is a bridge and it wraps around. Circle also we see very well. I don't think window is a little harsh, but nothing significant there. Segment involvement is 6, which will give you a P3. Calcium score is 390, which was, I don't remember exactly which was, it's probably P3. And then we see RCA, and you see there is a lot of blurring. So what additional modifier will we include here? No diagnostic. So, but we also have a significant looking stenosis. To me it looks severe. So if you have a 3 or a higher stenosis in one vessel and other is non-diagnostic, we include both the number and modifier n, but if it had everything else been mild, minimal or negative, then we just say CAD RADS n. We don't include any number. So in this case, looking at that LED, it looks like a 4. So 4A and a P3 and modifier n. Alright? Alright, yeah.
Alright. So the next case is a 45-year-old female with dyspnea on exertion. Look carefully at these coronary arteries. They are probably the largest coronary arteries that you will ever see. Whenever you see large coronary arteries, always look at their ostia to see where they are coming from and to see where are they terminating. So two differential diagnoses here. Is this an anomalous origin of a coronary artery, or is this a coronary artery cameral fistula? So as these images show, the left coronary artery is coming from the pulmonary artery here. So this is a case of alcapa. After going to the United States, I also learned that there is an animal called alpaca, which is different than alcapa. When this happens with the right coronary artery, then the diagnosis is arcapa. These patients are going to have a lot of collaterals and the flow is going to be reversed. That's why you will see the anterior wall is going to be thinned out in these patients. And there is accompanying volume rendered images there. So you can't assign a CAD RADS here. This is a CAD RADS E as an exemption. Right, and here is a still shot showing you that origin of the left coronary artery from the pulmonary artery. Next one, this is a patient with known systemic disease. I will tell you what disease that is in a second. How many people think that this is how many people think that this coronary artery is normal? Okay, glad that nobody thinks it is normal. Okay, how many think that there is a lot of soft tissue around the coronary artery? Okay, excellent. So there is indeed a lot of soft tissue around this coronary artery. This happens to be the distal left main and the proximal LED. The image on your right is a 1 minute delayed acquisition that shows that a lot of this soft tissue is enhancing. So this patient has again, CAD RADS E. This patient's known systemic disease is IgG4 related disease. So this patient had multiple organ involvement. So in our publications, we noticed that there are patterns of coronary involvement in IgG4. These are coronary ectasia, stenosis, pericoronary soft tissue, wall thickening, PD, as well as aneurysm formation.
I have one point to add. Like in this case, we didn't add any number because there is no narrowing, it's aneurysm. If there was a stenosis on top, then we would add that number. But in this case, because it's an aneurysm, there's no narrowing, so there is no number.
Exactly. Alright, next one.
Alright, so 40-year-old female, young woman with chest pain, ECG abnormalities, and calcium score of 0. And we have a coronary CTA curve planar reformat of the LED. And there is a corresponding cath the following day, and there is CTA of the renal artery, some irregularity there. And if you follow closely, look at the degree of opacification. Up to this point, it's very bright, then it's kind of a little grayish, and then again, it kind of almost obliterates the lumen, and then again, vessel opacification is good. So something going on in a young person. We are trying to show their renal artery, and there is a long segment kind of lesion in a young person. So how many think it's atherosclerosis? How many think it's vasculitis? How many think it's a dissection? Alright, yeah. So dissection is the correct answer, and we know that just by the appearance, a long tubular lesion, and there is some kind of spiraling of this lumen, although it's hard to appreciate on one view. And calcium score, again, no atherosclerosis and irregularity of the renal artery. So So it will be, and degree of stenosis, it's a short segment, almost obliterates the lumen. We usually call them 4A's severes. And so it's a 4A/E, and there is no plaque, so there is no PE here. E. That could have been a differential, but yes. Yeah, I mean, that's true, it could have been the case, but if I showed you the run of this angio, I mean, then this contrast never washed out from this dissected segment. And yeah, young women, renal artery abnormality, yeah, but could have been a thrombus. And yeah, actually, yeah, there is another case. Similar kind of story, not similar, young man, I mean relatively young, not that young, and mitral valve annuloplasty, recent drop in EF, elevated troponin in 1000, calcium score is 0. And there is a 4-chamber cine, and we see this wall not contracting very well. And there is this mitral valve annuloplasty, and there is this rounded thing sitting on top of it. And then we look at the ramus intermedius, which is exactly the territory that is abnormally moving. And we see this branch point, and there is almost an occlusion. So, how many think it could be a dissection? It could be, but looking at this finding in the valve, there is this rounded structure which kind of shows up. It may be a thrombus because of the valve issues and this filling defect sitting on top of it. It could also be redundant tissue after annuloplasty, but it was new from prior and we thought it was a thrombus. And it is a thrombus embolus lodged at a branch point, as they usually do. And more interestingly, patient was put on anticoagulation. So this was called a 5E, and put on anticoagulation, and several days later they did a cath. So now this is the same point. So now you don't see any filling defect. Here you see filling defect, I mean abrupt occlusion of the posterior subbranch. So maybe that thrombus dislodged and embolized more distally. Alright, 61-year-old female came to emergency with chest pain. Calcium score 39, segment involvement score is 2. We also have a function image. We can see there is some regional wall motion abnormality of the infralateral wall, which corresponds to this vessel, which is a obtuse marginal branch. RCA, LAD are relatively okay. How many think it is severe? We are looking at this area. Yeah, it looks severe to me. So it's a CAD RADS 4A with plaque burden will be 1 because it's a segment involvement of 2. So 4AP1. This is the corresponding cath, and you can see it's kind of very short segment, maybe a trickle of contrast going through. So 4A, patient was stented, did well. Another patient, 56-year-old male, stable angina.
Just 2 minutes.
Calcium score more than 1000. And there is a lesion in the RCA. LAD has multiple lesions. At least this one is severe. And then both OMs, this is one of the OMs, maybe a lesion here, another OM, maybe a lesion here. How many think it's a CAD RADS 4A? How many for 4B? Yeah, exactly. This is a 4B with a P4. Alright, another patient, 59-year-old male, history of coronary artery disease and prior sternotomy. What is the CAD RADS? And what is the most important modifier here? So there is a lima which looks patent, but there is another graft that goes to RCA which looks out. Another graft to the OM I couldn't identify. So it's a, how many think it's a CAD RADS 5? Yeah, so if a graft is down, that means a 5. And plaque, every segment is involved, so P4 and bypass graft. And this is the summary. This is the RCA graft, this is the graft to OM, they both are occluded. If you paid attention this morning, 32-year-old male chest pain, calcium score is 0. We don't see any but there is some black in the LED. And there is mean HU of 28. So, how many think it's a 4B? 4A? Yeah, looks severe. 4A. What is the P? Plaque burden. Calcium score is 0, segment involvement is 1, so E1, and high risk plaque. So 4A, E1, HRP. This is the IVUS, and patient underwent a CAD. It was a severe lesion, and it was stented. Last case. 54-year-old male, history of ASD repair with large pulmonary artery, and they have chest pain. And with the calcium score is 0, no plaque. Segment involvement is 0. But there is some, as this left main passes between pulmonary artery and aorta, there is maybe a little bit of flattening. So, how many think the CAD RADS should be 1, or it should just be E without any number? There should be a number as well, because there is some narrowing. It's an exception, but there is also some narrowing. So this will be a 1E rather than E. Alright, that's all. Thank you so much.
Thanks Vinit and Sandeep.